I think we're going to start. I think this watch here may be a little bit slow. I'm Hari Guman. I'm a director of child psychiatry here. And, it's a great pleasure for me to introduce today's speaker, Dr. Sally Boivy. When around this time we start thinking about our trainees finishing and leaving, and I'm sure they're thinking about what's going to happen next too. But let me tell you what she's going to be talking today. Her topic is correlation of presenting symptoms and diagnosis of autism spectrum disorders. And I don't think she has any financial disclosures, right? Let me tell you a little bit background of Dr. Boivy. She did her medical school at Loyola University Stritch School of Medicine, that's in Chicago, Illinois, right? And then she came to University of Arizona. She did her general psychiatry training here, and she has been in child psychiatry for the last 2 years. And before she went to medical school, there was a time when she was involved with a number of research projects, and she has written papers and book chapters and coordinated research at Harbor View Medical Center. When I look at trainees, myself, staff, I always look at like people, how good they are clinically, how is their potential for administration, teaching, research. And I have seen only few people who can do all those things. And with Dr. Boivy, I think she may be one of the person who can do that, and she has all those potential. And usually, when trainees are graduating, you worry about how they're going to do in this. Did we teach them? Are they going to be okay? But I don't have any concern about her. And the thing is, I'm not going to be saying goodbye to her because she's going to be working with us at Providence, where I'm medical director. So that's a very nice transition. Okay, Sally, thank you. Thank you for the presentation, and here you go. These are yours.
Well, thank you for that very nice introduction. Don't make me emotional before my talk, please. So I'm going to be talking today about some research I've been doing for the past 2 years, and really this research is the end of a long path of thinking about research from sort of day one of my residency. When my first year here, I applied for a grant from the American Psychiatric Association. It's their Institute for Research and Education, and I was working with Marlene Freeman at the time and Dr. Gellenberg, and I applied for the grant, and I got it. And really they have a section of the APA that just wants to do everything they can to get people into research and careers in research. And they want to expose you to as much as possible, and it's a really wonderful program. So they sent me to the APA 2 years in a row, Toronto and San Diego. It was all expense paid. And they gave me $2,500 stipend, which I used to go to the ACAP meeting this year in Hawaii. So it's been really good. So I don't know if that's a financial disclosure or not, but for those of you in training, I recommend you try to apply for these things because they can pay off. So Dr. Freeman left. I never came up with a full project idea. I started the Child Fellowship, and they were more than willing to have me switch my focus into the project that I did do. So that was my disclosure. So to start with, we all have heard that the prevalence of autistic spectrum disorders, or ASDs as I'll refer to them, has been increasing. We read about this in the newspaper. In 1943, during the time of Connor and Asperger's work, there were thought to be 2 to 4 per 10,000 people with autistic spectrum disorders. And for the students, Connor was the person that coined the term autism. And U.S. rates stayed similar, 3 per 10,000 in the 1970s, and they increased to 30 to 60 per 10,000 in the 1990s, according to the DHHS. And this was found to be similar in the United Kingdom as well. And most recently, the CDC has done surveys, and they looked at over 300,000 kids 8 years old at 11 different sites in the U.S., and they found the prevalence has increased to 1%. And they looked at different states, and the prevalence fluctuated, lowest in Florida at 4.2 and highest in Arizona at 10.4 among their study sites. And so this is an increase in 57% from 2002 to 2006. And studies around the world have shown similar changes. And so we don't know why this prevalence is increasing. There's a lot of talk of confounders, and maybe this isn't really accurate. And so I'm going to list a whole bunch of possibilities. But the first one is diagnostic practices differ in different places. And we know that there's been a decrease over the same time period in kids diagnosed with intellectual disability, and that's highly comorbid with autistic spectrum disorders. So it could be that they've just shifted the labeling. Diagnostic criteria differ between DSM-4 and ICD-10, where DSM-4 excludes children with schizophrenia from getting an autism diagnosis, and the ICD-10 does not, which is widely used in Europe. Autistic or specialty services to treat autistic kids really started in the 1980s, and now we know that there's something we can do to treat kids who have autism. So now there's a reason to give the diagnosis. Some places have systemic population screens, like England. Depending on the survey, the age of assessment will differ. You might not pick things up at a real young age, although all the recent studies say that you can. And then sometimes symptoms don't persist into adulthood, especially maybe a mild Asperger's. And so your rates are going to differ depending on the age that you look at. The caseload differs by location. For example, the Florida and Arizona comparison. There's financial and service incentives for children who receive the diagnosis of autism, so that may be increasing the prevalence. And there's a study by Skellern that showed that physicians were indeed upgrading diagnoses so kids could get services. And there's an increased awareness among parents and educators. For example, it was included in the 1991 Individuals with Disabilities Act that children with these disorders should get or are mandated to be provided with services. And of course, the media explosion. So the next 4 slides are just examples of this month. Some of the daily blurbs I get about newspaper articles. So this one was recent, where they're linking parental age to risk of autism, where they showed mothers over 30 are more likely than younger ones to have a child with autism, and older fathers contribute to the risk when the partner is younger. So when the mom is older, it doesn't seem to increase the risk. This one was real big in the news recently, where there was a paper in 1998 that linked vaccines to autism that was published in Lancet, and they recently retracted the article because it really wasn't empirically sound. This one is real current in terms of topical. With the DSM-5 coming out, they're looking at getting rid of the individual pervasive developmental disorders and just having one autistic spectrum disorder diagnosis with different sort of levels within just one diagnosis. So apparently people with Asperger's, who they call Aspies, are upset about this because they feel like their disease is very different from someone with autism. And then what we've been talking about, which is the increased prevalence. So this was the New York Times article about the CDC study that showed the prevalence increasing up to 1%. So we know early intervention is very important to treat these kids. We can do a lot to improve their functioning and outcomes. And there are problematic delays in evaluation and we know that parents and professionals often express concern about kids at younger ages, but by the time, it takes years sometimes for them to actually get a diagnosis. They're not identified by professionals until later. And so the same study that showed the increased prevalence by the CDC showed a median age of diagnosis at 41 to 60 months, so up to 5 years before they get diagnosed, which is real late when you're talking about early intervention. And there's a lot of referrals that happen before they finally receive the diagnosis. They're going from provider to provider. So early intervention is real important, but evaluation of autistic spectrum disorders is a lengthy and expensive process that often doesn't result in the diagnosis. In our clinic here, there's been a wait at times up to 6 months to schedule intakes for these kids with Dr. Jasmine Raghuman. It takes about 60 minutes to complete the ADOS, which is the interactive portion of the test that we do here, and then 90 minutes to complete the ADI, which is an extensive parental interview, understanding the symptoms that are happening. And then lots of time goes into the report writing. Extensive recommendations are made. So we want to be able to educate appropriate referral sources, increase specificity in the referrals that are coming in, and avoid unnecessary workup and expense. Meanwhile, not missing any kids, so making sure we're still sensitive. So this is an example of when kids are referred for evaluation of autistic spectrum disorders, how many actually get the diagnosis. And so 2 studies have looked at this, and between 42 and 53% of kids that come in for evaluation, that's how many actually get the diagnosis. And these are professionals doing the referring, so it kind of tells you how difficult it is to figure out what's going on. So again, it's difficult even for professionals to sort out what's going on. There was a study by Warren that trained pediatricians to do autism spectrum evaluations and diagnosis, and after the training, extensive training, they still were not very accurate. They were overdiagnosing, and there's a lot of associated factors that overlap with other diagnoses that are, well, there's a lot of factors that are associated with autism spectrum disorders that are discussed in the literature, but a lot of these are comorbid with other illnesses, and then there's a lot of comorbidity in general. So lots of kids get multiple diagnoses. So this is some of what's in the literature, and there's sort of more and less empirical support for different things that correlate with having autism. And on the left, there's more empirical support for impaired social interactions, stereotypic or repetitive behavior, language delay. Of course, those are the 3 big ways we get our diagnosis from the DSM-4. Intellectual disability, mood disorders, male gender, higher maternal and paternal age, and genetic influence, family history. And then there's still support, more case studies, and other less rigorous studies on high level of maternal education, higher family income, black race, higher socioeconomic status, gastrointestinal complaints, neurological symptoms, and genitourinary disease. And this is just a whole list of illnesses that are comorbid with autistic spectrum disorders, and there's studies that support all of these. Depending on where they're done, you can see schizophrenia. These must have been done in Europe. So this person did a study looking at comorbidity, and he found that in 137 patients with autistic spectrum disorders, the most common comorbid illness was schizophrenia. So obviously this wasn't done in the U.S. Then depression was next, adjustment reaction, anxiety, personality disorders, and dementia. So who truly needs to be evaluated? It would be nice if we had a predictive model to help us and help lay people and teachers, parents know who to send that really need to be evaluated. And prediction algorithms have been developed in high-risk samples of other diseases, for example, psychosis. This was an example of what was done in the psychosis literature. Cannon looked at a population with prodromal symptoms of psychosis, and he found that the positive predictive values for each of the, you can see the 3 univariate factors that some kids present with. If they present with suspicion and paranoia, they'd have between a 43 and 52% positive predictive value of going on to develop psychosis. And same with each of the individual factors, that's the range. But if you combine all 3 together, you increase the positive predictive value. That's the true positives. That's actually having the disease when you sort of test positive for it. If you combine them together, it goes up to 81%. So you get a lot more accurate. So this is a transition before we get into statistics. I just discovered this, and I'm a little late topically because the Olympics are over now. But I was watching the cross-country skiing, and this skier went flying off the course, actually. Fell down this ravine, hit a tree, and the announcer was talking about this frenetic course. And I didn't know what that meant. I'd never heard that before, so I wanted to look it up. But it's only found in the Urban Dictionary. And so I discovered this Urban Dictionary. So I put in a few new terms for you all throughout, and I made a few up of my own at the very end. So this is a mix between frantic and hectic. And actually, just to let you know, this woman ended up with a collapsed lung and 4 broken ribs from that, and she went on to win the bronze. So that's pretty cool. So the objectives of our study were to describe the patient population presenting to our infant, preschool, and developmental disorders clinics. These are the 2 clinics run by Dr. Jaswinder Guman here. We want to describe how many children were referred for autistic spectrum disorders and how many of those actually get the diagnosis. We want to understand what behaviors are concerning to our referral sources, understand who is referring so that we can target education to those people. We want to create a multivariate risk prediction algorithm. That's a model like the one I mentioned with psychosis. And overall, our goal is to educate the public and our referral sources so that they don't miss kids at risk, yet we use our limited resources appropriately. So as I'm going through this is kind of an initial run-through of all the data. And if anyone has any ideas about other things that we could do or could be done in the future, I would love to hear them. So our hypotheses, for those referred with for evaluation of an autistic spectrum disorder, our rates of diagnosis will be similar to rates published previously in the literature. Based both on the literature and on our clinical experience, we suggest that this long list of items, which I'll go through, will be correlated with receiving an autistic spectrum disorder diagnosis and help us predict who has an autistic spectrum disorder. So that's maternal age, GI illness, neurological illness, allergies, kidney disease, complicated birth history, language delay, social problems, stereotypic behavior, family history of autistic spectrum disorder, mood disorders, and male gender. And third are a large population of those presenting for evaluation of an autistic spectrum disorder actually end up with a diagnosis of ADHD. We were feeling like there was confusion and that maybe that's mostly what's going on. So the methods. We did a retrospective chart review between July 1st, 2003 and September 30th, 2008. This is the entire time that Dr. Gumon has been here. So all of her patients that go to both of her clinics. We reviewed notes in the charts, which included the initial intakes, progress notes, scheduling forms, and the Connors March developmental questionnaire. We actually collected more data than was used in this particular study, and I want to pause now to thank Beretti, who's sitting in the front row here, who was really my right-hand man for this project. He was extremely positive, energetic, and I think he deserves credit for actually getting this study done, so thank you, Beretti. But we collected as much as we could so that in the future we can do more studies and we'll have the information handy. And to explain the presenting symptoms category, these were without interviewer bias. So that means that these are spontaneously reported by parents. They weren't part of the history of present illness that we ask all the questions. It was just what the parents say. So it's their reason for referral on the pink intake that the clinic coordinators write down. The clinic coordinators write down. It's the chief complaint on the clinic intake note, and it was describe the problem on the Connors March developmental questionnaire, which they bring in with them. So unbiased information. And this is an example of presenting symptoms. We did a lot of coding. We tried to come up with general categories, which this is just an example of some of them. And for example, under mood symptoms, if it said moody, we'd put it under mood. If it said low self-esteem, emotional, very sensitive, we discussed it, and then we put it under mood. So we discussed a lot of items and tried to categorize them as best we could. So the subjects, initially 163 patients presented to the two clinics for consideration in this study, and we excluded 6 because they were recruited for participation in other studies, 3 because they're older than 18, and 3 because there weren't really any forms in the chart for some reason. And so the final study included 151 children. And this is the characteristics of the sample. The mean age was 6.3 years. The range was 1.1 to 17.5. 69, almost 70% male, 60% Caucasian, 21% Hispanic. Mostly professional referrals, but also lots of self-referrals. And then 56 of those 151 asked for an evaluation of autistic spectrum disorders. That's 37%. And our clinics are really divided up by age. So there's the little kids clinic, which is what I'm talking about here. There's school age, there's teenagers, and then we have an anxiety clinic. So basically every young child, unless they're going to the anxiety clinic, goes through her clinic, and 37% of people who bring in their young child want an autistic spectrum disorder evaluation. So here's my next word. This was the word of the day, February 19th. And I should caution you, if you go to the Urban Dictionary, it can be a little X-rated, so you might not want to, but some of them are funny. So this is a sensation you get that you will abruptly fall asleep at any moment during the day due to trying to watch as much of the Olympics as you can the night prior. TiVo or other recording device is the only known remedy. But actually, in my experience, TiVo makes it quite a bit worse. So now into the statistics. So all the data that we collected was grouped into 7 different domains or categories, and they're listed here: presenting symptoms, prior psychiatric diagnoses, family psychiatric history, past medical history, historical information, which was a lot of background information, a hodgepodge of things, developmental delays, and comorbid diagnoses. I know this is a busy slide, but across the top you can see the 7 domains or categories, and down below you can see what we listed or coded underneath each one. And then this is just a continuation of the same 7 categories and what we put under each one. So the statistical analysis. We initially did univariate correlations for each variable listed under the 7 domains. So for each item, each word that you see listed there, we did a correlation of whether or not it was associated with having an autistic spectrum disorder diagnosis. And we used point biserial correlations to compare dichotomous variables, yes/no answers, with continuous variables like maternal age, and biserial correlations to compare 2 dichotomous variables. And then, so that was the initial analysis, what's correlated. And then the second set of analyses were run to develop the model for lay people to be able to recognize which kids should be referred for ASD evaluation. And only 4 of those domains were really helpful in this endeavor. The others are just kind of extra information that we can use for other studies, or they just didn't fit the model. For example, a lay person is not going to know what the comorbid diagnosis is to use to help them decide if a child's at risk. So for the remaining 4 domains, only relevant items were included for further analysis, and actually most everything was included. We just dropped off a lot of items that didn't have any endorsements at all, or just weren't related to, it just didn't fit with being in the model. So after that initial correlation was run, we wanted to reduce redundancy or remove variables that were not independently predictive of getting the diagnosis. So we ran each of the 7, we ran 7 logistic, well 4 actually, because we decided to only use 4. So we ran 4 logistic regression analyses for each of the different domains. And the variables that remained statistically significant at the p less than 0.05 level were then entered into a single regression equation. So we basically collapsed those 4 categories that you see there and ran another logistic regression to remove more redundancy. And we were left with a few more variables that were left significant at the p less than 0.05 level. So the ones that were left after the 2 regression analyses were examined for their sensitivity, specificity, and accuracy, along with the combination, all combinations of them, to look at this model. And I'll go through this again, so it should be more clear later on. And accuracy is essentially a combination of sensitivity and specificity together. And the measures range from 0 to 1, with 0 a complete lack of sensitivity, for example, and 1 perfect sensitivity. So our results. 56 children were referred for an autism spectrum disorder evaluation, and 32 received the diagnosis. So that's 57%. Of the remaining 24 who were referred for an autism spectrum evaluation and did not receive the diagnosis, the following were made. So the most prevalent was anxiety at 37%, a speech problem at about 30%, ADHD was 16%, and you can see the remaining decreasing percentages. So this was a look at how many prior consultations were made before they got to us. So we collected data on who they'd seen before they got to us. And you can see that a lot of them had seen psychiatrists. They'd had school testing. They'd had a lot of different interventions before they got to us. And the next 4 slides are those initial correlations that were run. So within the 4 domains. So this domain was presenting symptoms, and you can see the ones that were correlated. And we ran it to the p less than 0.1 level, and that's very liberal so that we don't miss anybody. We wanted to include them all in the model. So you can see aggression was inversely related, mood symptoms, developmental delay, speech problems, expressive communication, stereotypic behavior. Self-injury was inversely correlated, and low frustration tolerance. Same thing under family history, the initial correlations. Psychosis was inversely correlated, autism, and Asperger's. Under the medical domain, past medical history, history of GI problems and GU problems, genital urinary, were correlated. And then under the milestone delays, there was some redundancy here because first we asked, was there delay, yes or no, and then we asked which ones were delayed. So we didn't really use those top 2 because they're redundant. We just used the bottom 3, motor, language, and self-help delays in the model. So essentially, we ran regression analyses on each of those 4 slides I just showed you, and the items that remained statistically significant at the p less than 0.05 level are listed here under each domain. So under developmental delays, language delay, it's presenting symptoms, it's lack of aggression, developmental delay, speech problems, and stereotypic behavior, it's repetitive things. And past medical history of GI problems and a family history of autism. So those were all the items that remained after the first regression analysis. Then we lumped them all together, all of these items, into a second regression analysis. And the items that still remained positive at the p less than 0.05 level were just 4 items: language delay, lack of aggression, speech problems, and a history of GI problems. So essentially we just whittled it down, reducing redundancy, reducing things that interact with each other and they were not independently predictive. So we got rid of everything and we're left with these 4 items that are highlighted in red. And now this is where I'm going to kind of have to read my notes because this is not my strong suit. And I'd like to actually thank Dr. Brightboard. He's sitting in the front here. He's our new psychologist who helped with the statistics. And actually this model was his idea. And it's really neat. He helped me really a lot and efficiently. And so I'm going to do my best to explain this. But if you have questions, he's willing to help me out. So to create the optimal model, predictive model, the sensitivity, specificity, and accuracy were examined for each of the 4 variables, as well as all possible combinations. And then notably, after we did a Bonferrari corrected alpha, which is essentially when you say p less than 0.05, that means the percent of a type 2 error is less than 5%. And when you run stats with all these variables, in order to continue with a type 2 error less than 5%, you have to really change the cutoff. That's what the Bonferrari correction is. So the corrected alpha is 0.003 versus typically you see 0.05, p less than 0.05. So the aggression was no longer independently predictive. But when you pair aggression with these other items in a model, they matter. So lack of aggression, not having aggression on its own, fell out after you corrected it. But if you leave it in and combine it with these other things, it becomes important. And he explained this to me as the peanut butter and jelly example, where if you have peanut butter on bread, it's really not great. Like, that would be the aggression on bread. If you have jam on bread, it's not that good. But if you put peanut butter and jelly together, it's great, and it matters, and it becomes significant. So the aggression is still left in the model. And if I didn't explain that correctly, okay, all right. So with regard to sensitivity, which is right here, the model that contained a language delay was the most sensitive at 0.83. In terms of specificity, the model with both language delay and a past medical history of a GI disorder was the most specific. Although you can see that several other variables were similar. This was 0.97, but there's 0.95, 0.94. The highest level of accuracy was the model with all 4 variables, and at 0.81. And the other models were kind of similar. I mean, they're right in there, 0.79, 0.80. But more statistics were done, which I can't explain to you exactly, something about the log. I should know that. But it turns out that the one with all 4 predictors was truly the best in terms of accuracy. So to determine which model was overall superior, we calculated the optimal combination variable, which was the average of each model's specificity, sensitivity, and accuracy. And the highest score on this one was 0.79. You can see 2 of them reached that level. And again, statistical convention dictates that the more parsimonious model, so the one with fewer variables, would be the better model. And that's the one with a lack of aggression and a delayed milestone of language. Although we've been talking about this, and clinically, we're thinking that the one with the GI problems might be important to include in the model. So we're still talking about this, and we're going to be rerunning things, as I'll talk about more in the conclusions. So my next word, snowpocalypse, snow plus apocalypse. And this is why I came to Arizona, basically. So our conclusions. So a large proportion of families presenting to the 2 clinics from July 2003 to September 2008 asked for an ASD evaluation. It was about a third. The rate of receiving an ASD diagnosis after referral for an ASD evaluation is similar in our clinic to published rates. So ours was 57% of the people asking for evaluation got the diagnosis. Previous rates were 42 to low 50s. So maybe people are a little more good at sending us people that truly have the illness. So our study was consistent with prior studies, which found gastrointestinal illness, language delay, stereotypic behavior, and genetic factors to be associated with autistic spectrum disorders. And our study did not find correlations between autistic spectrum disorders and social problems, which you might find to be a problem, considering that's how you make the diagnosis. But again, we were asking people, we weren't facilitating the conversation when we collected this data. We wanted their spontaneous, what is their problem? And the parents would say, it's a social problem, and that could mean anything. It could mean that the child is bossy. It could mean they have ADHD and they're extremely hyper. It could mean that they have a social capacity problem like an autistic spectrum disorder, or just no interest in social skills. So It just tells us that when we're asking these questions that we need to ask in a consistent manner, for example, using the ADI, and break down what the real issue is, and that's probably why our study didn't show that. It didn't show neurological illness, allergies, or kidney disease to be correlated with ASDs either, which is shown in the literature. So we're thinking we just need to have more studies, or maybe larger studies. And also, we were thinking that complicated birth history might be associated, because as we were collecting the data, we seemed to be writing out a lot of complicated birth histories. But when we look back, and I think that was just a lot of writing, and it stuck out in our mind, but when we look back, there were only 15 of, I think, 151 that had complicated birth histories. So this new variable that I haven't seen discussed in the literature was found to be correlated with ASDs when paired with other items, that being lack of aggression. So the aggression was inversely predictive when you pair it with other symptoms such as language delay or past medical history of GI illness. And that is not intuitive to me. I was thinking that aggression would be correlated. So we're going to be looking at that more closely. And people may be most likely to confuse symptoms of anxiety, speech disorders, and ADHD with those of autistic spectrum disorders, as these were the most common diagnoses given to those children who were referred for an ASD evaluation but did not receive the diagnosis. And our data is consistent with prior research, which has shown that children receive multiple referrals prior to receiving an ASD diagnosis. And so in terms of the model, both the two-factor model of lack of aggression and language delay and the three-factor model, which includes those two items, and additionally a history of gastrointestinal problems, provide optimal combinations of specificity, sensitivity, and accuracy among the available models. So this is another word. That's crazy. The perfect response when you haven't been listening at all. And you're not allowed to say that to me after the talk. So, limitations. We didn't include mood disorders as a collapse category, and sort of late in the study, I discovered that mood disorders were correlated in the literature. We had them all separated out. Also gender, I didn't realize was correlated until we'd already done the analysis, and also race. We didn't have sufficient information on intellectual disability, ethnicity, maternal age, or paternal age for these to be included in the model. Either that we didn't collect it or there just wasn't enough data in our study. There was some redundancy in the model where speech problems were described as a presenting symptom, where the parent spontaneously said it, and then language delay, which we asked them about milestones. And if you remember, both of those came out in that final model. So we may need to get rid of one or collapse the category. And then we had separated out under presenting symptoms expressive communication, receptive communication, nonverbal communication, and speech problems. So as we were going through the charts, we were trying to put each handwritten complaint into one of these categories, and it may have diluted out the data, so we're probably going to collapse those. So in the near future for this study, we're going to rerun the data, including new categories of lumped communication and speech categories, lumped mood disorders, and male gender. We'll review and rerun the analysis, including more of the review of systems probably, because as we were going back through the data, more items really stood out. For example, 4 had strabismus, which is cross-eyed, and many had multiple infections, which weren't just your typical infections. And this was a good reminder to me when I'm doing the review of systems on consults to categorize things in the correct category, because we had lots of asthma categorized under respiratory, and actually that's allergy. So I kind of learned from this project myself to think through what the underlying illness is when you're categorizing them. And then we're going to examine comorbidity further for rates and for use in a model possibly designed for professionals. Again, teachers aren't going to know what the comorbid illness is, but we as professionals may be able to, if we see there's a comorbid illness, that might help us predict who truly has an autistic spectrum disorder. So far future directions, this is kind of future research for us with the data. We may want to collect data on intellectual disability and paternal age. We could potentially evaluate those kids that we chose to do testing on, the ADI and the ADOS, which is an indication that we were strongly suspicious, to more carefully understand which symptoms were confusing even to us. So those kids that we did that testing on and who didn't get the diagnosis, where was the confusion? We could examine the path to care more carefully for these kids, the age of diagnosis, our services being started. We could examine this population further for other data that we have collected. So if any of you are interested in doing research, current medication trials, past medication trials, our treatment recommendations, are we consistent? Current services that they're receiving and prior psychiatric diagnoses that they received before getting to us. So I want to thank Dr. Jasmine Guman, who mentored me through this project. She was very available and gave me a lot of her time and expertise, so thank you for that. Dr. Brightboard, I mentioned before, he was a great statistician, great to work with, and made things very clear for me. Beretti, I already thanked. And then the fellows helped me, Antoine Adam and David Brooks. Some undergraduate students helped me, Julie Shaw and Felicia Uden. They've moved on after graduating. Natalie Mae Dixon, sitting in the back, she helped me with all the human subjects IRB approvals, and her assistant Chandra. And then Gail Jorgensen pulled a zillion charts and re-pulled them for us. And Leslie Armenta helped us with getting the information of who came through our clinic. And so these are the words I made up, which I won't go into now, but if you have any questions, you can ask me later. And this is kind of like supposed to be a chronology of my residency training and some of the crazy things that happened. So that's it. Any questions?